Hello, everybody. I'm speaking to a blank screen. Um, my name is Jacob Khurgin. I just wanted to say hello to everyone who has not met me. I am the Director of Men's Health and Infertility at the Division of Urology and Maimonides in Brooklyn. And it's a great pleasure and honor to be talking about a topic that I think is very interesting, male stress urinary incontinence. And this is geared towards the residents of New York and surrounding areas as per the Empire Urology Lecture Series. So we're going to try to keep it salient for test taking and just general knowledge. All right, so let's get started. I do have some disclosures. They're listed there. They're not really relevant to the discussion today. Let's go over the outline, what we'll talk about. Why are we talking about this? We'll do some introduction about the topic, and then the bulk of the talk will be about the guidelines, the AUA guidelines on the subject, and I'll finish up with some additional thoughts about the topic. So why are we discussing this? Well, number one, in case you don't know, in a couple of months, there's going to be this little in-service exam. So TikTok, it's going to be here before you know it, and SUI gets tested every year. And if you're thinking about going the SMSNA, don't worry, it is being offered. The in-service exam is being offered there, so keep that in mind. All right, but the real why are we doing this? Yes, test taking is important, but we do have patients who are suffering. Even though it's not cancer, we can really make a difference in patients' lives. That's the real why that we want to know about SUI and really any other topic in urology. And even that disgruntled patient, if he's leaking and you make him happier, you've done a real service. So, quick suggestions how to study. The AUA is obviously an awesome resource. The guidelines, the asterisk there is the majority of what we're going to talk about is from the guidelines. AUA has a great core curriculum and also a surgical video library, which is great. The textbooks, obviously Campbell's is our Bible and Hinman's is good for surgical atlas book. And articles, they keep, that's the most updated resource that comes out. You can always look for review articles about a topic you're interested in, meta-analysis, those are good. And also pretty much any article about a subject in the introduction and the discussion, they'll always gloss over at least some of the most salient topics, what's controversial potentially about the topic. So that's always helpful to pay attention to. And of course, that guy, oh my God, I had less gray hair. That was not even that long ago. Anyway, you can always review me going blah, blah, blah about this topic. So, all right, let's get started. Intro. So the majority is coming from this IPT guideline. The AOA and SUFU came out together in 2019 in this guideline about incontinence after prostate treatment. So even though we use stress urinary incontinence or male urinary incontinence or post-prostatectomy incontinence, BPI, the guideline prefers to use IPT, incontinence after prostate treatment. Why? Because it's exclusive. It's not exclusively radical prostatectomy patients. It could be BPH treatment, could be radiated patients who may not have had a radical prostatectomy. So IPT is going to be used preferentially. And in reality, we're going to be discussing stress urinary incontinence 90% of the time here. All right, so the guideline, AUA guidelines tend to be longer than this one, so it's actually a fairly short one. There's 36 statements. We'll go over all of them. They talk about the pre-prostate treatment, post-prostate treatment, IPT evaluation and treatment options, and then we'll also talk about post-op complications and special situations. All right, let's go. All right, so here are the statements about pre-prostate treatment. So in radical prostatectomy patients, it talks about what factors are affecting urinary incontinence. Also in radical prostatectomy patients, they'll talk about sexual arousal incontinence and climacturia. Again, prostatectomy patients, in general, they'll have short-term urinary incontinence pretty much universally, and then there's a general improvement to near baseline by the 1 year post-op mark. Another statement here, radical prostatectomy patients should be offered pelvic floor muscle training. And then post-radiation or salvage prostatectomy patients and patients who have had a TURP after radiation, you need to counsel them that they're going to have a very high rate of urinary incontinence. So the summary of what this is talking about is, counsel your patients preoperatively properly. Not surprising. So factor number one, statement number one, factors that affect urinary incontinence. There's patient factors, there's surgical factors. Patient factors, these are some beneficial factors. These are things that are going to be more associated with continence post-prostatectomy or post-treatment, being younger, having a smaller prostate, a longer membranous urethra. That's the part you leave behind after the prostatectomy. This is measured by MRI. Not as clear if it's beneficial to have a lower BMI. There's obviously other medical advantages to that, but possibly in the short term, you can regain continence quicker, although probably not long term any difference with your BMI. Things that we know surgically affect urinary incontinence, doing a bilateral nerve sparing. In one study at the 6-month mark, you were 26% more likely to have good continence than counterparts who are non-nerve sparing. So even in the patient with severe ED pre-op, and you think, well, I don't need to spare their nerves, there is another benefit in terms of their continence. Things that are not factors, and this is important, is the approach, whether it's an open or robotic prostatectomy, does not seem to be important. So why do I have this fine young man who looks kind of like Kid Rock's nephew or something? I don't know. This is, if you can't remember the factors that affect urinary incontinence, think of this guy. He's young and skinny. That's good. He has a small prostate. It's actually tiny. And he has a giantly long membranous urethra. And the surgeon was kind enough to spare his nerves bilaterally. So this is the guy who's going to do well with his continence, as far as we can tell. All right. One statement down and 30-something to go. All right, number 2, sexual arousal, incontinence, and climacteria. That took me like 20 minutes to do, that eggplant. So what is the definition? Sexual arousal incontinence is, as it sounds, a loss of urine during sexual arousal. Climacteria is also called orgasm-associated urinary incontinence, which is basically leakage at the time of orgasm. So about 30% of patients who have had a radical prostatectomy will have climacteria or sexual arousal incontinence, and you can actually have it if you've had radiation without prostatectomy. About half of patients find it bothersome, and about a third of patients will avoid sexual contact because of this. Why does it happen? Well, we think the internal urinary sphincter, which is removed during prostatectomy, coupled with deficiency of the external urinary sphincter and the detrusor contraction that often is associated with sexual activity, all that leads to urine loss. Some of the risk factors for this type of incontinence, well, if it's the surgery was recent, some evidence that if it was an open surgery rather than a robotic surgery, that's a risk factor. If you had a TURP prior to your prostatectomy, or if you have a shorter urethra, those things are all related with an increased risk of climacteria or sexual arousal incontinence. Things that are not factors: age, pre-op erectile function, and the nerve-sparing status do not seem to affect it. A little tidbit: climacteria is not the same as stress urinary incontinence. Often they coexist, but there's this 30% rule, give or take, which is you can have climacteria, and about 30% of the time you'll actually have no stress urinary incontinence otherwise. And conversely, you can have stress urinary incontinence, and about 30% of patients with that will not have any climacteria. So they're not exactly the same thing. All right, third statement. The time to recovery for urinary incontinence. At the time of Foley removal, urinary incontinence is expected. So it's something you should counsel patients about. And most patients, which by definition means more than 50%, at 12 months will be continent. Here's from the guideline, a continence recovery over time schematic. And we see that at the 12-month mark, the ratio of continent patients is closer to 1. And in the acute period, obviously, there is quite a decline in the continence rates. The blue is a robotic curve, and open is orange curve, and overall, we think they're similar, at least not statistically different. All right, statement 4. You should offer your patients pelvic floor muscle exercise and training. Probably better to do it pre-op if you can. There's no oncological contraindications, but post-op is fine as well. Basically, what you're doing is you're providing education to the patient about the anatomy, physiology, to be aware of the muscles that they need to control, and we think this is helpful. What's the difference between a muscle exercise versus muscle training? Basically, muscle exercise is you give them a handout and tell them this is what you're supposed to do at home, and training is with a physical therapist or other practitioner. A lot of things are not exactly clear about this. When are you supposed to start pelvic floor exercises? Some people say 3 to 4 weeks pre-op, but nobody knows. What's the best type of training? Do you use verbal or tactile clues? Do you use ultrasound imaging? Also, nobody knows for sure. And how often and how intense, if you will, does the training have to be? Is there benefit? The data is a little bit inconsistent, but if you're asked about this, the answer is pelvic floor muscle exercise or training will shorten the time to recovery. So in other words, they can gain their continence back faster. However, the final continence rates, whether they're incontinent or not continent, does not seem to be affected by this. On the bright side, there is no significant risk. So there is a statement later on that everybody should be offered it. All right, statement number 5. If a patient has had radiation therapy before, there's a very high risk of incontinence, urinary incontinence. So this is true in statement number 5, which is post prostatectomy and also post TURP. So in a salvage radical prostatectomy, there is about a 70% chance of urinary incontinence. So this is high, and patients should be counseled accordingly. About the same rates for open or robotic surgery. Patients who have had a radiation therapy, either brachy or external beam radiation, and undergo a TURP, also have about a 70% incontinence rate. We think the mechanism is related to radiation causing its known endarteritis, leading to tissue damage, fibrosis, and eventual decreased external urinary sphincter function. What about these ablative modalities, the HIFU and the cryo patients? Data is not really clear out there, but probably the rates are overall similar to the post-radiation therapy population. What are some risk factors for getting incontinence after this? Again, age is important. If you've had multiple TURPs, that's a risk factor. And if you have pre-op OAB, overactive bladder symptoms, that's usually bodes poorly for having more incontinence. So remember, Kid Rock's nephew again, good to be young, right? Good to be related to Kid Rock, not so sure, but good to be young, so you can be continent. All right. Again, statement number 5, post-radiation urinary incontinence. They recommend artificial urinary sphincter. This is directly from the guidelines. Patients undergoing TURP or salvage RP after primary non-surgical treatment for prostate cancer who are seeking long-term continence should be informed that they may require an artificial urinary sphincter. And in general, this is a picture I'm going to have a couple times during the presentation. If you see some sort of mention of radiation, think artificial urinary sphincter. In general, that's what the guidelines want you to do. If a patient has some radiation history, artificial urinary sphincter should be on your mind. All right, so now you have the patient who's undergone prostate treatment. Here are some guideline statements on this. Number 6, in radical prostatectomy patients, pelvic floor muscle exercises or training can be given immediately post-op. In patients who have had any sort of prostate treatment and have incontinence, you can offer them surgery as early as 6 months if they're not showing improvements in their incontinence. In the same population who is improving, but then at the 12-month mark or so, still have bothersome urinary incontinence, you can offer them surgery as well. So in summary, what this portion of the guidelines is talking about is when should we offer treatments, and usually it's either immediately in something that has no downsides, pelvic floor therapy, or if in the patient who's not having improvement 6 months and everybody's a candidate at 12 months if they're having any issues. All right, so immediately post-op pelvic floor, offered to all patients as soon as you remove the Foley. And when do you do exercises like just do this at home versus therapy? Well, if the patient requests it or if they're not getting the muscle exercises they're supposed to do at home. As I mentioned before, it probably shortens the time to recovery, but does not impact the final continence rate. So short-term, early recovery, which is defined as 3 to 6 months, recovery of continence. One randomized controlled trial showed that this helps, pelvic floor therapy helps. However, there was no difference at 12 months. So saying the same thing again. Back to this continence recovery over time graph, we see that in the early recovery period, you might have some benefit to pelvic floor exercises. However, at the 12-month mark, it's about the same. All right, statements 7 and 8. So surgery can be offered for either non-improving incontinence earlier at 6 months, or if the patient has had improvement but still has bothersome incontinence after prostate therapy, 12 months. One of the reasons is in post-radical prostatectomy, robotic radical prostatectomy patients, between month 6 and month 12 post-op, only about 4% of patients gain continence. In the other category, between months 12 and 24, only an additional 1% of patients gain continence. So it stands to reason it's reasonable to offer this because the chances of improvement are not that big. And these are guidelines. Of course, we're going to talk about this later, but don't forget about shared decision-making with your patients. We're not doing paternalistic medicine anymore. We got to tell them the risk benefits and then decide together. All right, next set of statements about the evaluation of the incontinent patient after prostate treatment. So in these patients, everybody needs an H&P, not surprising, obviously, and quote, appropriate diagnostic modalities. The goal here is to determine the type of incontinence they have, stress, mixed, urge, overflow, and also the bother. Just because a patient comes to you and says, I use 10 pads a day, if they're not bothered by it, you shouldn't be either. You can offer them treatment options, but it really is determined by how bothered they are. If the patient has urge incontinence symptoms or mixed incontinence, urinary incontinence, offer them OAB treatment as per guidelines on the subject. What kind of evaluation do surgical candidates for an SUI surgery need? Well, they need an H&P, obviously, and possibly ancillary testing. We'll talk about that. Patients who are incontinent need to be informed of their surgical and non-surgical options. That's a given. And you need to tell them about the risk, benefits, and expectations of the management options. Again, shared decision-making is important. And before undergoing incontinence surgery, perform cysto. One last thing, pre-stress incontinence surgery, you can perform UDS. The guideline doesn't say you have to, it says you may perform it. If, quote, it may facilitate diagnosis or counseling. So bottom line, everybody needs, before surgery, an H&P. That's to be understood, and a cystoscopy. That's recommended. Other things can be done, but they're optional. All right, so let's break them down. Statement number 9. Again, H&P. Some of the things you want to ask: what's the status of their prostate cancer? Is there no evidence of disease? Because that can change the time frame of when you can do something surgical. Have they had radiation? And again, what's the severity of the incontinence and how bothersome is it? Some things that are suggestive of stress versus urge incontinence. Well, if things worsen when they do anything with Valsalva, like straining, walking, coughing, sneezing, something like that, that's suggestive of stress incontinence. And if they tell you they have, guess what, urgency, and they can't defer that feeling before they lose some urine, that suggests urge incontinence. So what are some of these, quote, appropriate diagnostic modalities? Well, to quote the guideline, a clinician may choose advanced testing such as UDS. There is some evidence, some people say you could do a formal pad testing. It's either 1 hour or 24 hour with different weights that correspond with mild, moderate, or severe incontinence. There are some data showing that formal pad testing is fairly well approximated, with asking the standard, how many pads do you use, what type of pads, and how wet are these pads. So going back, that means formal pad testing can be done, but is not necessary to be done. All right. Statement number 10, if a patient has urge symptoms, offer them OAB treatment. In fact, OAB-like symptoms are pretty common post-radical prostatectomy. Urgency is present in about 1/5 of patients, and urge incontinence is about 6%, so not negligible. You treat them per the OAB guidelines. We got the meds, different meds. We've got Botox. We've got other things. We're not going to go over that, but you can do that. And at the same time, SUI is okay to be treated surgically. Most people who do slings and artificial sphincters will usually try to at least alleviate some of the urgency symptoms pre-op. And also, we often counsel patients that if they've had leakage for a long time and then you give them continence, you can develop secondarily OAB symptoms, and they can also be treated similar to pre-op. All right, statement 11. H&P and ancillary testing can be done pre-SUI surgery. History is remarkably good on its own, 95% positive and 100% negative predictive value. So just getting a good history can really tell you what's going on. The guidelines recommend an objective demonstration of incontinence, of stress incontinence. We'll talk about how that's done a little bit later, but this is also recommended by other guidelines, International Continence Society, and in the female SUI surgical management guideline from the AUA and SUFU. Even though they recommend demonstrating the presence of SUI, there is no evidence that this demonstration somehow improves post-op results. However, it is fairly easy to do. Some optional testing, like I mentioned, PAT tests, PVR. Probably a good idea to do this to make sure that the patient is not experiencing overflow incontinence. There's some uncertainty of what volume is significant. Is 150 okay, 200, 100, symptoms or no symptoms? So a little nebulous there. Urodynamics, probably the most useful when there is diagnostic uncertainty. So someone is describing both stress and urgency type symptoms, or they're not a good historian, or they're high surgical risk candidate, and you really want to make sure you have the diagnosis down. Also, if you're concerned about impaired compliance, that's something that you can counsel them pre-op as well. But again, UDS is optional, as is pad testing and PVR. All right, statements 12 and 13. You should give info on management options and shared decision-making. This is a given, obviously. We want to educate our patients. We tell them about the options, such as absorbent pads, come in different types. We also tell them about an external device, the penile compression device, or also a clamp. This is something that they can wear. They do have to take it off every 2 hours or so. They can't wear it too much, or else they can get some necrosis of the penis, which is a bad place to get necrosis. But that's what one of them looks like. That's a Wiesner clamp. Catheters, those are all options. I'm not going to show you what catheters look like because you're urology residents and you probably see them quite a bit. One thing to keep in mind is that patients with bad incontinence, if you put an SP tube in them and the bladder neck and external urinary sphincter are open, they can still leak. And of course, tell them about the pelvic floor, training, and exercise. So some things to consider, constant incontinence will lead to skin irritation, and that's something that it can be obviously really important to patients. You have to potentially use a catheter if they're getting excoriation or skin breakdown. Also financially, some insurance companies are not paying for enough pads, and this is an out-of-pocket expense. So that's something to talk to the patient about. And again, shared decision-making, what is that? Physician and patient are working together. You got your physician, you got your patient. The physician is supposed to present the medical evidence and, of course, listen and honor the preference of the patient. The patient's responsibility is to provide accurate information, ask questions if they don't know something or don't understand something, and share their opinions. Together, this is shared decision-making and has been proven to lead to amazing Press-Ganey scores, good improvement in patient satisfaction. All right, statement 14, cystoscopy should be done before undergoing incontinence surgery. Why? Well, you can assess the anatomy. Some people have strictures, bladder neck contractures, or vesicourethral anastomotic stenoses. If you have tumors, that does change things, stones, other things. When you're doing a cystoscopy, please evaluate the external urinary sphincter. This is especially true if they're going to, if you're considering a sling insertion, because really you should be able to see volitional contraction. In other words, you park your scope right outside the external urinary sphincter and tell them to pretend they're stopping their urine. And you can actually see the sphincter going like that. You need to see some movement for a decent chance for the sling to work. The International Continence Society guideline on AUS from almost a decade ago also agrees that a cysto should be done pre-op whenever it's, quote, feasible. One alternative that has been suggested is if you can't see the patient pre-op because you're so important and they're so busy, well, you can do an intraoperative cystoscopy, not cyst. In other words, you counsel them ahead of time that, okay, we're going to look inside, and before we make an incision, we'll evaluate things. However, if let's say you see a bad stricture or a bladder tumor or something, the patient needs to know that there is a reasonable chance that surgery will be aborted and to be done some other time. Statement 15, may, not obligated, but may perform UDS before incontinence surgery. Quote, it can be helpful in situations. So if you're suspecting some sphincter or bladder dysfunction, or you have concerns about the bladder capacity, the presence of bladder outlet obstruction, it's not unreasonable to do a UDS. Again, not mandatory. About 35% of the time when you evaluate them with UDS, these patients will not show stress incontinence. A lot of times it could be because the catheter itself is occlusive, so you got to remove it, and you can demonstrate SUI in most situations then. So even though we get concerned about detrusor overactivity, small capacity bladder, poor bladder compliance, there's not great evidence that doing a UDS, excuse me, doing a UDS will lead to any benefits post-op in terms of outcomes. As urologists, we do care about poor compliance. We're taught to protect the kidneys, the upper tract. While poor compliance is generally fairly rare, it is more common in patients with severe radiation cystitis because of all those fibrotic changes to the bladder, and definitely reasonable to periodically image the upper tracts and check the creatinine to make sure there's no dysfunction because of that. You can treat this with anticholinergics, Botox, if the compliance is poor. All right, let's talk about incontinence after prostate treatment, different treatment options. Statement 16, this is one of the longer sections, but Statement 16, in radical prostatectomy patients, offer them pelvic floor muscle exercises and therapy, as we previously mentioned. 17, all patients with incontinence after prostate treatment can be offered an AUS. So AUS is sort of a universal fix-all, if you will. If someone has SUI, that's not a wrong question. Question 18 talks about the exception to that. So if you have a AUS potential candidate, you do need to make sure that they have enough both physical, manual dexterity, and cognitive ability that they'll need to operate this device. For patients who are undergoing an AUS insertion, the guidelines recommend a perineal and single cuff approach. We'll talk about that. If someone has mild or moderate stress incontinence, a sling is something that can be considered. And a corollary to that, if you have stress incontinence and severe leakage, slings should not be, quote, routinely performed. Sometimes there's a role for this, but as a rule, if it's severe incontinence, don't give them a sling, give them an artificial sphincter. You can offer adjustable balloon devices for patients with mild stress incontinence. This is not a lot of data on this, but we'll go over that. Patients who have undergone BPH treatment, like TURP or a simple prostatectomy and have stress incontinence, you're actually offering them pretty much the same surgical options as you would in the radical prostatectomy group. Guideline statement number 24. Patients who have had radiation and have stress incontinence, an AUS is preferred over the other options of sling and adjustable balloons. Patients with incontinence after prostate treatment who are interested about urethral bulking agents, you can do this, but you have to counsel them that it has a low efficacy and rare cure rate. Statement number 26, any other treatment options except for the ones listed should be considered investigational, and patients should be counseled accordingly. So in summary, this section is everybody could get pelvic floor muscle exercises or therapy. AUS can almost always be an option for patients with incontinence, and don't choose sling or adjustable balloon devices in patients who have severe incontinence. All right, let's keep going. So pelvic floor should be offered for all radical prostatectomy patients. How does it work? Well, we think it increases the muscle strength and also the blood flow. So it makes sense that the external urinary sphincter may recover sooner, but maybe not necessarily the final continence rates, as we discussed before. It's safe. There's really no adverse events. Maybe their patients and the practitioner's time. So really, there's no downside. Overall, the data has been heterogeneous. One of the reasons is there's different approaches of how to treatment. There's different approaches in defining what incontinence and what continence is. And because of this, we can't say things definitively, but some randomized control studies suggest that there is benefit to this and others no. Again, the downside is pretty minimal. Statement 17, if someone has SUI, and AUS can be offered. Any type of severity of incontinence, and why this is based on the fact that long-term continence is usually present after AUS placement, and also it's associated with a high patient satisfaction. AUS, we'll talk about this later, is not without its risks, and patients should be counseled. Then you can get persistent leakage. In other words, it might not always work. It's a mechanical device, and therefore it can fail. You can also get more concerning side effects or risks of erosion and infection. These are all operative to fix. What are the rates? Well, there's one study with a 2-year follow-up that showed about 1/5 of patients, 20%, will have complete continence after AUS insertion, and about 55 and 22% will have a very small amount of drops. So usually they're pretty happy. I don't know if they gave the participants a teaspoon and said, please measure it, but about 22% had 1 teaspoon or less of leakage per day. This study showed high satisfaction rates. So about 92% of patients said, if I could do it again, I would. I would go through AUS surgery again. And about 96% would recommend surgery to a friend. They did not ask what you would recommend to an enemy, but I'm assuming the number would be similar. All right. Another study with a slightly longer follow-up showed that AUS is pretty effective at reducing the pads per day, which went from about 4 pre-op to about 0.6 pads post-op. I always think that the brochures for all kinds of men's health and other medical issues are always funny. There's always somebody who's super happy and smiling. But taking this directly from the Boston Scientific patient brochure, you can see that the reported satisfaction rates are in the 90s or 80s. And this is fairly accurate. It is a pretty high satisfaction rate. So yeah, this is actually, remember that guy who was pretty unhappy? Look how happy he is now that he had an AUS placed. So, be nice to him. All right. Guideline statement 18. So the patient needs to have some degree of physical and cognitive abilities before you can do an AUS on them. Some manual dexterity and some understanding, comprehension of how the device works. A simple thing to do is have the patient demonstrate taking the taking the pump, which we'll show you later, and just squeezing it between their index finger and thumb. If they can do that, great. If they can't do it, and trust me, there are patients who cannot, they might not be a good candidate for an AUS. Yeah, so if they can press that little area right here, which is going to be sitting underneath the scrotal skin later, then that's all the manual dexterity they usually need. All right, statement 19. If you're doing an AUS, the guidelines recommend a perineal, not a scrotal approach, and a single cuff rather than 2 cuffs in tandem. So let's go over why they came up with this recommendation. Probably the main reason perineal appears to be superior to a scrotal approach is because you can't get as proximal from a scrotal approach as a perineal approach. Other data that is fairly compelling. In the short term, about 9% of the perineal approach in one study required explantation, whereas it was 19 or about twice as much in the scrotal. The continence rate was higher in the perineal group, and complete means 0 pads a day, and social means up to 1 pad a day. Sometimes you see those definitions. Also, perineal approach resulted in less revision surgery. So all these things led to the recommendation of a perineal approach. Single versus tandem, well, the continence rates are similar. So we go by the complications. Explant rate is about 4 times higher in the tandem cuff group than a single cuff group. And complications are also higher in the tandem or lower in the single cuff. So based on this, we recommend a single cuff. And this used to be a little bit more of controversial in the field prior to the availability of a 3.5 centimeter cuff, which allows continence even with some of the most compromised urethras out there. So perineal single cuff approach, of course, but some universal truths about about prosthetic surgery. Obviously, use sterile technique. Don't do this in your backyard. Antibiotics, you can refer to the other AUA best practice statement on this. You can't tell ahead of time what the cuff size will be. This is an intra-op measurement. You have to make sure that the AUS or the IPP, whatever you're doing, the connections are watertight, or else it will fail. And before you close them up, make sure that the device is working. What happens if you encounter urethral injury? Either you can see the Foley, or we irrigate through a catheter. If you see urethral injury, you're done. Stop. You don't have to. You can't put the device in anymore. Possibly in the future, 3 to 6 months later, you can reattempt, but the answer is always urethral injury, abort. That's also true for IPP surgery. All right. Statement 20. Consider a sling in patients who have incontinence after prostate treatment if they have mild or moderate stress incontinence. So again, sling, mild or moderate, AUS up to severe as well. Some data on the cure rates, in other words, complete resolution of incontinence. There's a total of about 14 studies, some prospective, some retrospective, but about 750 patients with a cure rate, which is up to social continence of 1 pad per day, about 62%. Improvement, this was defined in a couple of studies, 10 studies in 500 patients, as at least a reduction of 50% in pads per day or pad weight. This was only 34%. One of the things in sling surgery that's often excluded is if the patient had a history of radiation therapy or TURP. They're usually excluded. So later on, we'll talk about this subset of patients, but there's not a lot of patients out there in studies. Often they also exclude patients with really severe incontinence, which is defined as listed there. But if these sling studies if these sling studies include the severe incontinence patients, then that's the subgroup that has the highest failure rate. Slings generally have a low rate of complications, and if they do, it usually goes away. Retention can happen and usually resolves by about a week post-op. They can get pelvic or perineal pain or paresthesias. That also resolves usually by the 12-week mark. Erosions are rare, but if they're present, they must be explanted. And what happens to your patient who had a sling for incontinence and has persistent incontinence? Well, you can offer them a sling revision or another sling or an AUS. Again, we'll talk about that a little bit later, but most of the time an AUS is recommended. Statement number 21, not usually for severe SUI. So again, slings for mild or moderate, AUS are probably the best option for severe SUI. In severe SUI considered AUS, you may consider slings in the non-radiated patient. the patient who may be a clean freak and changes their pads 10 times a day, but they're actually not that incontinent, and they can tell you that at night they don't have any incontinence. What do you do with a patient who just has really weak hands or anatomic issues and they can't press an AUS pump, or they're just not understanding? You might only be able to help them with a sling. Here's a cartoon of what a sling looks like. Basically, sits there. It has no moving parts, so if it works, it doesn't have anything that can leak, and it acts as support and maybe to lengthen the urethra, the functional urethral length, and we think that's how it works. This is a transobturator pictorial here. All right, full disclosure, adjustable balloon devices. I've never done this, but we know a little bit about it. Guidelines are saying you can offer this, but only if there's mild SUI in these patients. The reason is because it's fairly recent. We don't have a lot of data. It was only approved in the US in 2017. The approval says for intrinsic sphincteric deficiency in men who previously had a prostatectomy or a TURP. The overall data says about a 70% cure rate. Looks like, again, no radiation is something that portends better outcomes. And again, better outcomes in mild SUI, hence the recommendation. One study with about 12 months of follow-up showed that there was some efficacy in severe SUI from 5 to 1.8 pads per day. The real reason that the guideline seems to be hesitant about offering this is the complication rate seems to be higher than slings or AUSs. About 30% will have some sort of complication within one study that had 2 years of follow-up. This is what it looks like. This is inserted into the perineum, basically to sit right next to the bladder neck region. Initially, it's placed like this, and then with contrast, so you can see it on fluoroscopy. These balloons are inflated to the left and to the right to provide the continence. The trade name is ProAct, and this is where it's supposed to sit. The nifty thing about it is that this is connected by tubes to a little port that's accessible through the skin. So if they have incomplete continence, theoretically, you can, in the office, cleanse the skin, insert a needle and give them a little bit more fluid and increase their continence. And also if they're going into retention, they maybe have too much fluid in the balloon, you can take some out through the same port. So that's the adjustability is an interesting concept. Okay, the surgical management of patients with incontinence post-BPH treatment is the same as post-radical prostatectomy patients. So what are some post-BPH treatments? TURP, endoscopic enucleation like HOLEP, and a simple prostatectomy, either done open or robotic. Overall, the rate of stress incontinence, persistent stress incontinence in the post-BPH treatment population is about 8%, so it's not negligible. The evaluation is similar to the post-radical prostatectomy patient, and again, you can offer the same surgical management, although we don't have as much data. As mentioned before, BPH and radiation therapy patients are often excluded from these SUI surgical management studies. How does AUS fare in patients who have post-BPH treatment SUI? Well, one study was randomized controlled, looked at AUS versus injectables, which is not really fair. That's like, an MMC fighter going up against me. AUS is going to win, so is the MMC fighter. So anyway, the dry rate or cure rate was higher at the AUS as expected, with an odds ratio of 5.7. Another study showed that AUS in this post-bph treatment population had a satisfaction rate of about 90%, and similar improvement rates. Surgical revision was not was about 1 out of 4 patients. How about Sling? Well, the data is even less on this, but one study with only about 18 patients using a transobturator sling showed that about 60% of patients had an improvement or a cure rate. In another study with a quadripolar, which is a sling that has both arms going this way and that way, we'll show you a little later, showed slightly better results of about 75% cure or improvement rate. However, the N was only 8. So these are really small studies. Just wanted to quickly show the transobturator versus the quadripolar sling. So this is what the current AMS or Boston Scientific Advanced XP sling looks like. It's just a mesh that you put in the right place, whereas the quadripolar, in addition to having the TOT, has a compressive effect from the other 2 arms. And it comes with a special retractor, and these are the trocars. All right. So again, we have this paradigm of someone with radiation, and the guideline, as expected, says go ahead and do an AUS, not a sling, not an adjustable balloon device. So the preference in the post-radiation patient is AUS. How does radiation affect things? Again, endarteritis causes small vessel injury, which eventually leads to ischemia and ultimately the final stages of fibrosis and necrosis. We've all dealt with poor patients who have had lasting effects from radiation therapy. So in this patient, assuming that they are okay, they don't have any ongoing hematuria, their bladder neck is stable and open, we have to counsel them. As expected, in the radiation population, they're going to have higher rates of complications and lower rates of success. Let's go through some of the numbers. Overall continence rates in the post-radiation population is about 2/3, 66%. There was one study that looked specifically at the population of radiated patients and non-radiated patients with a pretty significant difference, with continence of about 56% in the radiated group and about 90% in the non-radiated group. How about complications? There was one study showed about a 16% increase in the need for revision in the radiated versus the non-radiated population. The main reason for needing revision in the radiated population was erosion. Again, the urethra is damaged from radiation exposure, and the mechanical device that's always squeezing can erode through that frail tissue. Whereas in the non-radiated group, erosion was not as common. Urethral atrophy was the reason for revision rate most commonly in the non-radiated population. So why don't we give slings, or why don't we offer slings? I mean, this is a guideline, so you could do what you want. This is not set in stone. But in general, the sling insertion in a patient who's had radiation appears to not be as effective, and also with time, the efficacy seems to wane. There is a subset of patients where you might consider a sling in the post-radiation setting, patients with mild incontinence who don't want to undergo an AUS insertion. There's not a lot of data on this, and again, it's still not recommended. So please, if you have a question about this on the tests, the in-service or otherwise, choose AUS. All right, a word about urethral bulking agents. The statement is low efficacy and low cure rate. Bulking agents are not FDA approved in men, they are in women. The data is, again, scant and also variable. There's different material that we use. The sample sizes are generally small with short follow-up. Definitions of success or failure are different. The one advantage the urethral bulking has going for it is it's not very invasive. However, the disadvantage is that it's the least effective of these management options that we're talking about. On average, it lasts about 6 months. Improvement occurs in about 50%. Cure, the low cure rate that the guideline is talking about is about 1 out of 6. And interestingly, about 1 or 2% will have worsening of their symptoms, probably because the injection is done into the sphincter and compromises its ability to coapt. All right. Which patients may benefit from urethral bulking agents? Again, shared decision making, but let's say the patient's old and frail and are poor surgical candidate in general. Probably better if the patient has no bladder neck contracture and no radiation history. It's not without complications. Retention occurs in about 18%. Almost all patients get some degree of frequency or dysuria or other urinary symptoms, and UTI occurs in about 6%. Statement number 26. Treatment options that weren't discussed up to now in the incontinence after prostate treatment guideline should be considered investigational. So non-investigational, pelvic floor, AUS, Sling, as we've discussed. However, investigational, some things are promising, some things are quackery, but all these things listed here are considered investigational. If the patient is interested, asks you a bunch of questions and brings you that 20 articles about the topic, see if you can refer them to a place that's doing a clinical trial. All right. Post-op complications. So statement number 27, patients who have had an AUS, tell them that the AUS tends to, with time, reduce in effectiveness, and also that reoperation is not a rare event. It's fairly common. Statement 28, and the patient who had an AUS or a Sling, but has persistent or recurrent incontinence, basically you have to go back to the drawing board and do an H&P and consider other investigations to figure out why that's happening. Statement number 29, patients who have had a Sling surgery but have persistent and recurrent incontinence, as we previously alluded to, an AUS is the recommendation, not another Sling. Patients who have undergone an AUS and have persistent incontinence or recurrent incontinence, you can consider surgical revision. My takeaway for this is nothing is perfect. Surgeries may need reoperation. You have to tell your patients about that. All right, let's go over statement number 27, and maybe we'll go into a little bit more depth about what these AUS devices look like. So statement number 27, AUS counseling should include that there's a potential for loss of efficacy with time and that the need for reoperation is fairly common. So artificial urinary sphincter, there's 3 components. One component is the urethral cuff. There it is. This is something that you measure intra-op to know the dimensions of the patient's anatomy. Do they have a healthy urethra and atrophic urethra? But these come in varying sizes. The PRV, or the pressure regulating balloon, is a reservoir that exerts a constant amount of pressure. The most common one is 61 to 70 centimeters of water, and this is what provides constant pressure from here, transferred through the tubing down into the perineum, and is constantly giving enough pressure to keep the patient continent. Patient has to void, so we give him a control pump. That's this guy right here. Everything is internal, obviously, but this is placed in a fairly accessible location, usually in the left or right hemiscrotum in the subdartos pouch, so they can press it. When they press right here, that gets fluid to be cycled back into the pressure regulating balloon, which means the cuff is opened. That means now they can void. The pressure regulating balloon, after about a minute or so, will start to close off the cuff, and they regain their continence. So the patient only has to do one thing. When they need to pee, they press this and they pee. If they need to pee again, they do it again. There is no button to close. It closes automatically again because of the PRB, the pressure regulating balloon, is exerting that force. Okay. So let's talk about failure rates and things we should be counseling patients on. Failure rates increase with time. About 1/4 of patients at 5 years will have failure, and about half of patients at 10 years will have failure. How do you manage this? Well, you remove and replace the device. This is something you need to talk with your patient about. It's not urgent. It's not an infection. They might say, nah, listen, doc, I don't want to do any more surgery. That's fine. It's their preference. In these failures, the durability and efficacy is similar to the initial surgery. How about an infection? Infections are not very common, less than 5%. The patient will come in and say, hey, something hurts. They might have purulence. They might have systemic symptoms. And this is a much more of an urgent situation. You need to manage it urgently. Maybe not that minute or two, but in the next day or two is probably prudent. So you got to remove the device, remove everything, and you do not place a new device in the same setting in an infected field. About 3 months, maybe 6 months later, you can consider a replacement. Cuff erosion. This is not a rare event, up to 10% in some series. The most common reason is urethral manipulation. So the patient's out there, maybe they're obtunded for whatever reason, and someone shoves a 24 French Foley in them, or someone gets cystoscopy done, some sort of urethral manipulation, and all that pressure causes an erosion. I've seen op reports where people had an AUS, and someone thought that they had a stricture, so they did dilations or DVIUs, and guess what? Cuff erosion occurred. Another fairly common reason, especially in the early period, if you have a cuff erosion, you might have had urethral injury at the time of the placement of the device that you didn't recognize. However, with constant pressure, that urethral injury got larger and larger, and now you have an erosion. Patients will usually have symptoms related to their voiding. They'll have dysuria, hematuria, and sometimes if it erodes fully, now the thing is completely closed and they can't pee. They're in retention. You diagnose this with history and physical exam, but importantly, cystoscopy. You can see plastic where plastic shouldn't be, and this also needs to be explanted. Once the device, either an AUS or an IPP or any other device, is in contact with the urinary tract, it's by default either infected or going to be infected soon. So you need to explant it. After explantation, catheter should be placed about 3-4 weeks, and again, you can consider replacement sometime in the future. What about the patient who comes to you and says the incontinence never went away, or it went away and now it returned? They might have urethral atrophy. You might have sized them incorrectly with your cuff, or they might have had some sort of trauma or something intraoperatively where the fluid that's supposed to be in the system has been lost. Here's some general principles about reoperation in these patients. It can be challenging, but number one, wait. It's not to be done in the acute setting. 3 months, some people say 6 months, but importantly, not in the acute setting. If you had a previous cuff, try to find a virgin territory on the urethra, ideally more proximally if you can, because that provides better continence, but importantly, not at the same location if you can help it. For some really compromised urethras, a transcorporal approach can be considered. We'll go over that in a minute. Here's some pictures, what an AUS erosion looks like. On the left, I would say it's a cystoscopy. Yeah, you're not supposed to see, a foreign body eroding through the urethral lumen. This is an intraoperative finding. You can see this is the cuff, and it's eaten away. It's in the lumen of the urethra. It shouldn't be there. Not trancorporal, but transcorporal. Apologies for the spelling error. But what does a standard cuff placement look like? This is the urethra. You're leaving the corpora alone, and this is where the cuff is, giving the gentle pressure to maintain continence. A transcorporal is done this way, where you're actually taking a little bit of the corporal tissue, which helps kind of bulk up a otherwise compromised urethra. This is what it looks like intra-op. This is a nice picture where this is the urethra, this is the urethra. As you can see, the surgeon marked out a portion of the corpora. He's going to incise that, and then he's going to incorporate that in addition to the urethra, and the cuff is going to be transferred from here, and it's going to include a piece of the corporal tissue. Okay, statement 28, we're home stretching. So what do you do with the persistent or recurrent incontinence after the patient has undergone a sling or an AUS? So H&P and other optional investigations. So as always, H&P, H&P, H&P. Some things that can cause this persistent or recurrent incontinence could be something surgical, like at the time of surgery, you chose an incorrect cuff size, too big. There can also be a leak, even if you put like a little needle through the tubing inadvertently, you don't notice it. There's a constant leak, one drop every hour or two. Eventually, you're going to lose all the fluid in your system, and it's not going to work. There's a little cuff tab. Let me see if I can find a picture here. There's a cuff tab somewhere, which can slip off, and then the AUS device is no longer working. Yeah, there it is. This little cuff. It helps you place it, but if you don't do it correctly, and this area right here slips off, you can have incontinence occur. Sorry, where's my? Okay. So cuff tab slippage. Another etiology for this recurrent or persistent incontinence can be patient or physician related. As I mentioned, some urethral manipulation or some other misadventure. Dog bites them in the area, boom, doesn't work. Inadvertently, once in a while, the patients will be trying to press the soft part and will press the deactivation button. We'll go over that in a second as well. But they can inadvertently deactivate it, and if it's open, it's not going to work. The device itself, it has a shelf life. There's wear and tear. It might stop working. That could be one of the etiologies. Constant pressure can cause urethral atrophy, or it's called subcuff urethral atrophy. And of course, erosion. All these things can make the device not work anymore. So what can you do? In addition to your H&P, you can consider some sort of imaging especially at the pressure regulating balloon. It's usually inflated with 23 cc's of saline, injectable saline. If it's still there, if the fluid is still visible, either by ultrasound or CAT scan, then a leak is unlikely. If it's not there, then a leak is very likely. Another thing, you could do a cystoscopy, make sure there's no erosion, anything else, and you can press the pump and see if the cuff is cycling. In other words, does it open when you press it and then slowly close? If the patient has OAB symptoms, it's not uncommon to have de novo urgency and other OAB symptoms after gaining continence. So they may need a UDS, and just like any urethral manipulation, it's recommended to deflate the cuff and deactivate it. And we'll show you later how to do that as well. In the patient who's had a sling but has persistent or recurrent incontinence, AUS is recommended. Why do we have this patient population? Either they had partial or completely no efficacy and they're not happy, they want to do something else, AUS should be offered, or they've had an infection or erosion of their sling, not common, but those are patients who may benefit from an AUS after they heal. As mentioned, infection and erosion rates in the sling population are low. You diagnose it with H&P and a cystoscopy, and just like any erosion or infection in the prosthetic world, urgent explantation is recommended. Again, catheterization for about 3 to 4 weeks and consider replacement months later. So how about this patient who underwent sling insertion, has persistent or recurrent incontinence, and you're trying to think, well, let me do another sling on him. What does the literature show? It shows that you have a slightly less than 50% chance of cure, which is to say 0 or maybe 1 pad per day, but the satisfaction rate is about 70%. So it's an option, but not what the guidelines recommend. There's a study showing what do you do in this population who basically failed a sling insertion. What if you do a repeat sling versus an AUS? So a study with 60 patients, about half and half. Retrospective showed about a 45% success rate with a sling, whereas AUS was upwards of 90%. So the conclusion from the guideline panel was an AUS should be used following sling failure. Guideline number 30. We only have about 6 left, guys. So what do you do in the patient who had an AUS and now has persistent or recurrent incontinence? Well, you can consider revision. Again, H&P, if they're not your patient, get the op report, figure out what cuff size was used, where all the components are. Sometimes I get a dry CT. If I'm not 100% sure, I can palpate everything. Why is this happening? Well, maybe the cuff size was too large intraoperatively initially. Maybe the pressure regulating balloon, 99% of the time we use 61 to 70 centimeters of water, but maybe it was inadequate. So what can you do? You can change things about the cuff. You can move it more proximally. The more proximal the cuff is placed on the urethra, the more likely you are to have good continence rates. You can give a smaller cuff if the anatomy shows that. And transcorporal, as previously mentioned, is an option. Pressure regulating balloon, make sure it's in a low pressure space. It shouldn't have any external pressure, which can really mess with the functionality of the device. Things that the guidelines do not recommend is tandem cuffs, like I previously mentioned, 2 cuffs together, you don't need that. And grafts, where you try to basically bulk up the diameter of the urethra, those are not recommended. They're associated with high complication and infection rates. And again, in this population, if you are doing a revision surgery, in general, the durability and efficacy is similar to the initial surgery, with an important exception, the patient with urethral erosion. The urethra, once it's compromised, every other surgery is going to be more difficult. All right. Special situations. These are the last few statements. Let's go over this. So when you have an erosion, either after a sling or a sphincter placement, you need to explant, do it soon, but do not re-implant. You can re-implant in the future, but do not re-implant right away. Patients with incontinence after prostate treatment, if they have really poor quality of life, failures of many other treatments, urinary diversion can be considered in carefully selected patients. This is an uncommon thing, but is on the table in the right patients. If a patient has bothersome climacteria or sexual arousal-induced incontinence, it's okay to offer them treatment. And statement number 34, patients who've had urethroplasty or other urethral reconstruction surgery, an AUS should be offered, not a sling, but they should be counseled that they have a higher complication rate. Patients who have both incontinence after prostate treatment and they have erectile dysfunction, can you give them a sling or an AUS and an IPP or a malleable penile prosthesis at the same time, or stage it? The guidelines say you can do either. If the patient has any urethral pathology, but especially bladder neck contracture, this should be treated before they get incontinence surgery. So my summary of this is erosions need to be explanted and can be reimplanted, but in a delayed fashion. And if the patient has other issues, it's okay to treat them, but do it judiciously. All right, let's go over this last few statements. So someone who's had an erosion, they need explantation and delayed reimplantation. This is just a principle in prosthetic urology. You explant everything, remove all the components, do a washout. If you have a patient with an AUS who has an infection, I'm gonna call so. Sorry. If you have an infected AUS device, have a high suspicion that there's an erosion somewhere. Often that's the case. If you do find an erosion intraoperatively as you're explanting things, especially if it's a large urethral defect, repairing it rather than just purely putting a Foley may decrease the ultimate stricture rate. So that's something to consider. Again, catheterization, 3-4 weeks. As mentioned, avoid immediate device replacement. Even studies where they did a washout and the patient didn't have any gross purulence, the results were not very good. Delayed, once the infection or other issues have resolved, delayed implantation is fine. All right, urinary diversion in the quote, motivated and properly counseled patient with incontinence. So if these are patients who have really poor quality of life, this is something you consider. So who are the typical candidates? Someone who's had a sling, then an AUS, and then a stricture, and then a bladder neck, and then another surgery, and failed this, and urethral atrophy. Basically, the devastated lower urinary tract is really the candidate. Refractory bladder neck contracture, patients with severe refractory detrusor overactivity, or patients who have had upper tract compromise due to lower urinary tract dysfunction. These are candidates. You can do it with or without the cystectomy, depending on the situation. A supratrigonal cystectomy is sometimes done. This can be a continent or an incontinent diversion, such as the Mitrofanoff, the Monti, also ileal conduit. This is beyond the scope of this lecture, but those are all options. And in patients who are not great candidates for surgery otherwise, or have had, a lot of abdominal surgery, you can give them a suprapubic tube with closure of the bladder neck, or else they'll continue to leak from below. How about the patients with climactorrhea? Feel free to offer them treatment. Some of the conservative treatments to consider, well, tincture of time, about 2/3 of the time. If you wait, things will improve. You can also tell them, hey, you could do some behavioral changes, void prior to sexual intimacy, use a condom, pelvic floor therapy may be helpful. Medications, they're all off-label, but imipramine, which is a tricyclic antidepressant, has some modest effects in some patients. Elderly patients should be given this medication with caution due to potential neurological issues. A variable tension loop is basically a fancy rubber band that you can place, and it occludes the urethra. There is some data that distress goes down in patients from 14 to 2% if they use this, and partners also from 60% to 11% have some reduction in distress. So these are all conservative treatments. Nothing wrong with that. Tell your patients about them. In terms of surgical options, the data is not as good. There's scant data, but likely it's successful. There's this is not mentioned in the guidelines, but something called the mini jupette sling. A jupette, I believe, means a small skirt in French. Ends up looking like a little mesh. Ends up looking like a skirt. I guess someone who has a lot of imagination said that. But basically, you do an IPP, a penoscrotal approach to the IPP, and then in the corporotomies on the medial aspect of them, you take this little bit of mesh and you sew it in there. And the idea is that every time that they pump their device, the mesh is going to dig in a little bit into the urethra and give extra continence and stop climacturia from happening. Success rates, despite small numbers, are good. They're above 90%. And the expectation of AUS and sling insertion to improve climacturia is probably about the same as the rates of improvements in stress urinary incontinence. So a patient who's had urethral reconstruction, such as urethroplasty, can get an AUS, but overall has higher complication rates. These anterior or posterior urethral strictures, or more accurately stenosis when it's posterior, may have pre-existed their prostate treatment, or may occur post-radiation, post-radical prostatectomy, or even your own treatments can cause it. AUS is preferred if they've had a urethral reconstruction history. You do have to tell them that they may have a decrease in the device lifespan. This may result from compromise to the urethral blood supply from previous surgery. And if the urethra is very compromised, a transcorporal approach may be a good idea. This is a direct quote. Given post-surgical changes related to most types of urethral reconstruction in the posterior and anterior urethra, male slings will not be effective. So in other words, AUS is again the option. As you can see, there's a theme whenever things get complicated: radiation, prior surgery, severe incontinence, reconstruction. AUS tends to be the answer, not sling for the tests. All right. What about the patient who has both incontinence and ED? The guideline says you can either do at the same setting. You could do an IPP and an AUS, for example, or you can stage it. The safety, there's overall mixed data. Some earlier reports were talking about doing concomitant surgery at the same time may have increased risks. The more recent reports say that doing everything at the same setting is probably safe. The continence, sexual function, and patient satisfaction rates are similar in concomitant surgery compared to stage surgery. There's one study looking at penile prosthesis and AUS placement in the same setting versus penile prosthesis placement alone. And there was suggestion that the more complicated surgery had a higher reoperation rate, which is not necessarily surprising. And if you are considering that as the patient's surgeon, you have to counsel them accordingly. If the patient has a bladder neck contracture, or more accurately speaking, a vesicourethral anastomotic stenosis, that's identified in your mandatory cysto before surgery, please treat this first. If you can't get it treated definitively, they should not actually undergo anti-incontinence surgery. While treatment does not cause incontinence, a lot of patients, because of a stenotic bladder neck, will have pseudo improvement in their incontinence. So you have to tell them, if I open this up, your incontinence may worsen. After you treat them, you have to reassess with cysto. Most places recommend at least waiting a month to see whether recurrence is present or not. Again, AUS is recommended more than sling in these patients because of increased success, and also because we may have had their baseline incontinence worsen. So what do you do with a patient who has had an AUS or a sling, and now they have a bladder neck contracture recurrence? You didn't listen to the guidelines. You didn't fix this beforehand. Well, this can lead to erosion, especially if you continue to do endoscopic management, especially with a sphincter. And then this can be infected and needs to be explanted. In these difficult situations, you can use a really small caliber scope, like a ureteroscope, and use a holmium laser to try to open up the contracture. Okay, so that was statement number 36. Pretty much done with the guidelines. It's not interactive, so obviously I can't answer your questions, but if you do have questions, I think we have a live session coming up in a couple of months where you'll all be free to ask questions. So please write them down. I'll be happy to do my best to answer them. I did want to kind of give a few additional thoughts about this. I wanted to simplify what I do, my pre-SUI surgery evaluation. Put my face there again, because why not? So yes, everybody gets an H&P. The things you have to concentrate on are, in my opinion, pads per day and how bothersome things are. I don't use pad weights. I think that's cumbersome and difficult to do. A very important question: have you had radiation therapy? That does change management quite a bit. Again, leaning towards an AUS rather than a sling. And then I do ask them to do, I'll show you what it's called. It's called a male incontinence grading scale, but I do ask the patients to cough and demonstrate SUI in front of you. I also do a PVR and exam to make sure that there's no overflow incontinence. Urine studies, obviously, to make sure there's no active infection. If there's microhematuria, you might want to work about, and cystoscopy. So H&P, urine studies, and cystoscopy on everybody. Whether they need anything else depends on the situation, but that's the minimum. There is a very nice grading scale developed by Al Morey out in Texas called the Male Stress Incontinence Grading Scale. I think it's pretty clever. But basically, you tell a patient not to void for about an hour, so they have some urine in their bladder. They stand and they cough 4 times in front of you. Very intimate situation, but this gives you the ability to grade them from 0. They've coughed, you don't see any leakage at all. 1 is they cough, 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 nothing, and then you see a couple of drops. That's grade 1. As soon as they cough, they have a few drops. That's grade 2. Grade 3 is a stream in a delayed fashion. So any stream is at least a grade 3, and some floridly incontinent patients will cough and a stream will come out right away. So why is this helpful? You can compare your pre and post-op, grading, but in general, Dr. Morey's recommendations were grade 2 and less, probably are sling candidates, and grades 3 and 4, any stream, are more likely to benefit from AUS insertion rather than sling. This goes along with the guideline recommendation with severe incontinence. AUS is probably recommended over slings. Another thing I wanted to talk about real quick, what do you do with a patient who has had surgery, either a sling or an AUS for their incontinence, and they need a catheter? So the nice thing about slings, really, you just put a catheter in. There's really no contraindications. You're not really afraid of anything. Once in a while, a coude will be helpful since you've kind of displaced the urethra by a few centimeters, and a coude might help you. But as a rule, a sling, you just put a catheter in. AUSs are different. We've seen this a few times. Our ER colleagues sometimes ignore the AUS, or some urologists who are not aware might cause some trauma. So the right way to catheterize a patient with an AUS is to deactivate the device first and foremost. If you're going to use a Foley, please use a smaller one, 12 French or less in caliber. And if the patient is going to need prolonged catheterization, prolonged is either a day or 2, but definitely 3 or 4 days, it's time to consider an SB tube. Eventually, there'll be an erosion if you continue to keep that Foley in. So we talk about deactivating. Well, when do you do it and how do you do it? So you definitely deactivate the device at the time of the initial surgery. In fact, make sure it's working, and then you open the cuff, count a little bit, and deactivate it. So that's everybody. If someone, like I previously mentioned, needs some sort of urethral Foley or cystoscopy, that's a good time to deactivate them. And once in a while, you get the patient who's had an AUS years ago, they've had a cognitive decline, and you don't want them to have a chronic catheter, and you obviously don't want them to be in retention, so you open it up and deactivate it. How do you do it? There's a little picture coming up, but basically you squeeze the soft part through the skin, you'll feel it. Your fingers come together. That opens things. And you get a little dimple or concavity in the soft part. And you wait a little bit, allow things to fill up just a little bit. Usually I count to 3 or 4 Mississippi, 1 Mississippi, 2 Mississippi, 3 Mississippi, 4. And then you press that deactivation button firmly. You don't get any tactile feedback whether you were successful or not. After a minute or two, you can feel again through the skin that their dimple is still there. Then you can be rest assured that you deactivated things correctly. Anybody know who this is? Obviously, I can't hear you answering, but the AUS device is complicated enough that even urologists have a hard time figuring it out. But think about what a genius you had to be to come up with it. And in fact, this is a picture of Dr. F. Brantley Scott, who died in the 1990s from a plane crash, actually. He was about 60. He came up with this. This is the original schematic. Obviously, it's changed, but the initial paper from 1973 had 5 patients with 100% continence rate after this. So this was a really milestone in prosthetic urology. Interestingly, 4 out of 5 patients were female, and 4 out of 5 patients had neurogenic rather than stress incontinence. The age ranges were from teenage to 40s. All right, so why do we deactivate? Why is a Foley so dangerous in the AUS? Well, this slide took me like an hour to make, but here's a Foley going into the urethra, right? You're putting it in there. Now, if it's not deactivated, if it's closed, you have pressure on the urethra, both from the inside, where you just put the Foley in, and from the outside. So all around, you're getting pressure, and eventually this is going to be really bad news. I've seen it before. So a prolonged Foley, all that pressure causes ischemia. Eventually you get erosion. The patient will be infected. The device will not work. And now this sick patient who needs a Foley will need emergent surgery. So bad news. How do you reactivate? One of the reasons that you count to 3 or 4 Mississippis is you're waiting for a little bit of fluid to come back into the soft part. Why do we do that? Because you need a little bit of fluid in there to be able to reactivate things. So the way you do it is you squeeze the lower part of the pump, which should have, again, that little dimple. You press it forcefully. A lot of times you'll feel a release or a rush of fluid. Sometimes you can even hear a little like sound. And then the dimple disappears. This becomes nice and flat. And now the device cycles again. The patient needs to void, they press it, it'll open, they void, it closes on its own. Once in a while, if this is not reactivating easily, or whoever deactivated it didn't wait enough and there's not enough fluid in here, it gets a little complicated, but you can either troubleshoot by pressing on the side of where the deactivation button is, or sometimes actually from behind, use something like a cotton swab, like a Q-tip, or even the eraser from a pencil to apply force to allow fluid to come back in here so you can reactivate. That's about it. If anybody has any questions, obviously you can't ask right now, but write it down. I'll be happy to do my best. And here's some shameless plug of my progeny, both my boys, Aiden and Sebastian. They're also happy that we're finally done. All right. Thank you, everybody, and I'll see you in the flesh in a couple months.